Copia. All right.
All right, everyone, good afternoon. So we're gonna start. Um, there are some questions we're gonna chat about, and then if you guys feel that more questions or more stuff need to be discussed, please let me know. Uh, the first question I have here is about isosorbide versus Renexa. I'm not really an isosorbide guy at all. I don't like nitrates, never been proven to affect survival or mortality. Never been part of the GDMT. Everybody knows about nitroglycerin underneath the tongue, but never been a study done, randomized clinical trial to justify the use of nitroglycerin. By all means, you can use it, obviously, and it's necessary to be used. But as far as isosorbate mononitrate is not really been used in frequently in clinical trials at all, and we don't have good data about it. Terrible medication that can give you headache, but if you have patient with CAD that you can't operate on, or you have patients with microvascular disease, it's reasonable to use medications like that. Now, that's different from isosorbate dinitrate that was in the BIDAL trial, where it was tried in African American patients with HFrEF, heart failure with reduced ejection fraction, that you cannot control blood pressure on beta blockers and ACE inhibitors back in the day. They start using isosorbate dinitrate and hydralazine, and actually it was proven to show efficacy. Now, we cannot replay these studies again after use of more of aldactone, MRAs, or the SGL2 inhibitors. But there's certainly still a validity for the use of these medications. Now, for CAD, the isosorbate mononitrate, I rarely use it, but Renexa, we use it for microvascular disease, and Renexa is some kind of Vaughan Williams classification of medications. It's like kind of sodium channel blocker. It affects the action potential a little bit, and it has been used sometimes in VT management. The trial, I think called RAID trial, did not really show any benefit from the arrhythmia part of Renexa, uh, but at the same time, the pain medication effect is there. You can use it when it's as last resort in certain patient that you feel it's microvascular disease or the disease is so severe that you cannot intervene on. And that's after GDMT, after statin, high statin, antiplatelet agents, beta blockers, and so forth. But I'm not a fan of isosorbide. I'm not a fan of digoxin, as probably most of you know. Again, there's validity for using both of them. Either the Renexa is 500 twice a day or 1,000 twice a day.
Where should you start?
Hmm?
Start at 500 BID?
You start 500 BID, and then you take into consideration the age of your patient and the size of your patient as well. It's always there's always difference between starting medication the same dose in somebody with volume of distribution is higher because of 400 pounds versus a tiny lady 120 pounds. So take that into consideration. Age factor is very important. Your metabolism in the liver and the kidneys will be affected as well as you get older. GFR is going to come down. So there are certain stuff that you have to keep in your mind when you utilize medications like that. So the GDMT for coronary artery disease. Now, there are two kinds of coronary artery disease. There is a coronary artery disease stable, and you had stress test. Stress test was abnormal, LED 90% on CAT, then stent. Versus CAD, you had non-STEMI or STEMI, went to the hospital, troponin was elevated, and we gave you a stent. So kind of a different approach. The first one is the stable one is not high risk. The one in the setting of MI is high risk. So you have to be careful about that. Number one, you have to manage is risk factors, right? You know, your diabetes should be less than 7%, your blood pressure should be less than 140 systolic. You have to have physical activities. Now in nursing homes, it's going to be a little bit difficult, but that's one of the risk factors modifiers, which is, you know, the physical activity. Statin, high intensity statin, Lipitor 80 or Crestor 40, that's called high intensity statins. We try not to use Zocor or Pravastatin anymore. Now there's some data about Pravastatin being less harmful and less painful when it comes to muscle aches. So if you see it in some patient population, there may be a reason for that, you know, they had some muscle aches because of Lipitor or Crestor. And then beta blockers, trials when they were done for beta blockers, they were done for 2 to 3 years. Nowadays we try to utilize them for the first 2 years after MI for sure. And if you have decreased ejection fraction less than 50%. So if you have MI, history of MI, I would utilize statin. I would utilize beta blockers. I think there's better validity for them for even extended part of extended time beyond 2 3 years. And if your EF less than 50%, there's actually a huge benefit for them. And in that case, it's going to be under the HEF-REF guidelines and GDMT. Now, if they cannot handle statin, either PCSK9 inhibitor, Repatha, for instance, or the Leqvio, the new medication that actually you can utilize every 6 months. I love it. I love it. I love this medication. It's quite expensive. It's in an infusion center. So that you have to keep that in your mind. But for the nursing home facilities, I think if you can introduce some statins, that would be the best way to do it. Dual antiplatelet therapy, dual antiplatelet therapy after PCI. So there's actually a lot of changes happened recently. The scaffold of the stent changed. When they started doing the stents in the late 80s, early 90s, the stent thrombosis was about 16% if you stop dual antiplatelet agents. Nowadays is barely 1 to 2%, even less than that. The scaffold changed, the way we do the stent changed, the structure changed as well. So likelihood of having kind of thrombosis because of the stent is minimal. Now, if you do stent in the setting of MI, most of them like to have 1 year of dual antiplatelet agents. If you do stent in the setting of stable angina, the dual antiplatelet agent between 3 to 6 months. Nowadays, there are a lot of stents you can utilize. The third generation stents you can utilize and dual antiplatelet agent for only 1 month actually. And there's some data, strong data about 1 month dual antiplatelet agents, and then beyond that, single antiplatelet agent. We prefer to be either Plavix or Effient or the Brilinta. So, but if your patient want to be on aspirin only, then I would recommend pushing that beyond 6 months. Then you can do aspirin only on this patient. So, the too many anti-thrombotic medications, such as the antiplatelet agents, anticoagulation. We used to love them. We used to actually use them aggressively, but actually we were doing mistakes. And we have to be very careful. We have to be the advocate for these patients. We have to, you know, make sure that some of these patients, they really have extremely high risk of having bleeding, especially at older age. You know, older ladies above the age of 80, they are very fragile and they really have higher tendency to bleed. So stable angina, I wouldn't continue. Stable angina and stenting, I would not continue dual antiplatelet agent beyond 6 months. And if you're a patient after MI and you do stent and you feel there's some anemia and some blood loss and maybe bleeding, I would stop the antiplatelet agent, dual antiplatelet agent, just start either aspirin or some Plavix on these patients. And if you sometimes you have to do every other day Plavix, so do every other day Plavix for somebody who's hemoglobin 7.6, for instance. They would live in misery if your hemoglobin. Think about it and try it. Hemoglobin 7.6, 8.1, 8.2. Yeah, they feel miserable. So these patients really need to be, their issues need to be considered and their lifestyle need to be considered because your energy level is going to be very minimized by your low hemoglobin. So being less aggressive with antiplatelet agents is the way we do it. Again, there's actually new data about only dual antiplatelet agents for 1 month only, and then beyond that, just single antiplatelet agent. There's a question about regional wall motion abnormalities that does not always indicate CAD disease. Does not always indicate CAD disease. Right bundle branch block, left bundle branch block, pacemaker, a history of open heart surgery, any kind of open heart surgery. It will give you this quivering in the septum. So CAD, the regional wall motion abnormalities do not always indicate CAD disease. And I don't know. I mean, I would be very careful about sending somebody for heart catheterization. Maybe I would send for imaging, but heart catheterization based on wall motion abnormalities. I mean, at certain stage in patient's life and beyond this 8 years of age, you really need to have good reason for you to be aggressive in these patients. And patient is having some chest pains. You do echocardiogram, wall motion abnormalities. Yeah, that might probably hide 90% LAD or circ or RCA, but if you have somebody who's sitting and you're checking mitral valve, and here you go, you have some wall motion abnormalities, you got to take it in clinical context. Similar to EKG, by the way. How many times you do EKG and you find T-wave inversion? Ischemic changes. The AI will read it as ischemic, which is rightly so, right? But I tell my nurses here, my PAs here, that you got to take it in clinical context. In other words, patient is laughing with you. Would you send him for heart cath? No. Patient is stable, blood pressure is okay, everything seems to be okay. Patient is having some lower stomach ache and some ST wave changes, or ST wave depression. I mean, I would not really panic about it. So patients having chest tightness or confusion. If one of your patients at facility is having confusion, actually MI might appear as confusion in certain patient population. So in that case, yes, I would be concerned. But beyond that, any ST depression or T-wave inversion, you have to send for heart cath. I would be very careful about that. If you have some suspicious, do some imaging, and let's just get more information about your patients and be able to utilize what you have. One of my mentors, actually, Dr. Vernon Anderson. His name was all over the ACC, AHA, big shot. Used to actually, I will never advocate for that, but used to say, why would you use your stethoscope if you have echocardiogram? That was 2008, 2009 when I was in training. So, I mean, obviously, I'm not advocating for not utilizing your stethoscope, but utilize your diagnostic imagings and get more information if you think that more information needs to be taken, or needs to be considered. That's what I would say. And individualized therapy right now. You have somebody who's 91 years old, some chest tightness. At sometimes blood pressure is 180. Let's control blood pressure first before we panic. And little stomach aches, ST2F changes in somebody who's 87 years of age. That could be probably GI issues. Did they have a bowel movement in the last couple of days? I would really try to avoid being aggressive unless I need to. Um, that's the way I think we have to practice medicine nowadays. Again, take everything into consideration and use your judgment in certain patients. As long as you're not really ignoring the issue, I think you should be fine. I mean, you can justify whatever hey, this is at that moment, this is what I thought. So nobody can penalize you for that. Any questions?
Follow-up question on that. So if we're getting a routine echo, patient, like you said, has no cardiac complaints, and we see the regional wall motion abnormality, what should then be the next step for these providers in nursing homes? Everything, risks are mitigated, patient's asymptomatic. Do we repeat an echo sooner? Do we do further workup in the
So-
nursing home?
So, I mean, number one, if EF is below 50%, we have to investigate a little bit more. And we have to take into consideration, is it some wheelchair bound or some not very active or somebody with mild to moderate dementia? In that case, I would leave it alone and repeat probably in 6 months or so. But if somebody who's very active or reasonably active and EF is like 40%, I would investigate more, and maybe at some point you may need to do kid stress test or PET scan or something like that.
Does Renexa have as much of a blood pressure pull as isosorbide can?
No.
Good.
No. Actually, there's another aspect. There was question used to come on the board exam all the time. Patient has a history of cabbage, has been having angina symptoms. Blood pressure is 102 systolic. Would you add beta blocker? Would you do something? Would you stop one of the blood pressure medication? What would you do? The answer is going to be you stop one of the blood pressure medications because 102 is not good enough to provide you with good blood supply, and these patients by default will, similar to anemia, will have angina symptoms. So you have to be careful about lower blood pressure. Today we had a lady, 85 years old, came into the clinic. She's doing great. Everything is awesome. She's on losartan 100. She's on a little bit of aldactone. She is on amlodipine 5. So what blood pressure was 114. Her blood pressure at home is like 110, 120. So I said, let's cut down on the losartan. So always keep in your mind patient age and the fact they are aging, and you always need to adjust their medications and try to treat the polypharmacy in these patients. Try to minimize medications as much as you can. 97-year-old lady came into me today, Lipitor 40. I told them, I mean, she could hardly hear anything. I told them just stop the Lipitor. Uh, so had a couple admissions to the hospital because of hypertensive urgency. We kept her blood pressure medications, but we did not feel that the Lipitor is going to change much in somebody who's 97 years of age. Now, 80 plus is different story, right? But 97, once you cross the 90, I think you have to be mindful about your medications. Any questions, guys?
Hey, Doc.
Hey,
It's
Ajay.
me. I have this patient in he's 70 and intermittent chest pain. Nurses would call me, hey, can you put, like, he was in Ranexa before and then they couldn't avail it, so I changed him to ISMN. But we couldn't I can't figure out if it's from his heart or, but he's a daily smoker. So I did an echo and it showed the pacemaker wire, but he can't remember having a pacemaker. So I'm not sure how to move forward. Do I do a stress test? Because this chest pain he's having is like it just comes even when he's watching TV, he said. And his blood pressure is up and down as well. So we stop it and then we add it.
How old is he?
70.
Yeah, I mean, it's not bad idea actually to do stress or PET scan on him. I think D can help with the PET scan arrangement. I don't think it's a bad idea to do that, but the pacemaker wire,
Yeah.
you have to, you felt him?
Yeah, there's nothing. Like there's no, that's
You,
weird.
th- you think is leadless pacemaker maybe? Does he have dialysis catheter?
I believe he had a transient dialysis in the past. No, he doesn't at the moment.
So I don't know. Pacemaker wire, either you have it or you don't have it.
Right. So
Uh,
I talked to our Miss Jamie if we could like interrogate it, but don't think she did.
but you did not feel pacemaker.
No, sir.
Okay. I don't, that's really interesting, actually. I would like to look at the echocardiogram, actually, to see if there's any indication for, because sometimes actually uh, artifact can appear as pacer wire in the right ventricle. So
Mm.
not every pacemaker wire appearance will be pacemaker.
Okay.
Sometimes it's really difficult to tell. Maybe they said possible, so maybe just artifact.
He has cabbage times 4, 2009, and it's the pacemaker said pacemaker while seen at the right ventricle.
Yeah, I don't know. I don't know if you were not able to feel it. Is he with it?
Yeah, his ambulatory. He smokes like every smoke break.
Yes.
So I'm just like watching him closely because sometimes this chest pain just comes, and he said,
Right.
"What's going on?" And
Yeah, I would do some kind of stress test on him. Talk to D,
yes,
and
sir.
let's see if we can help with that.
Yes, sir. Thank you.
Any question, guys? So, all right. Do you think, why don't you send whatever topic we want us to chat about, you want us to chat about to D, and then we can discuss it.
Doc, real quick.
Hey, Whitney.
Sorry. What about dual antiplatelet therapy post stroke?
Yes.
Do you have, should we be asking for neuro to see and making recommendations? Or, because sometimes I see they'll say for like the 30 days post stroke
Right.
or post TIA or whatever. And then other times it gets added with no recommendation as far as stopping.
So it really decreased the risk of stroke, but at the price of increasing the risk of bleeding. And right now, actually, we utilize it for 1 month. You're right, 1 to 3 months after the stroke, and then beyond that, we do single antiplatelet agent. For me, myself, uh, and I know that from multiple trials before that if you had stroke on de novo, no antiplatelet, you do aspirin. If you have stroke on antiplatelet, which is aspirin, you change the aspirin to Plavix. The dual antiplatelet agent it's actually came because of the idea of the stroke may recur or higher risk of recurring stroke within the first 14 days to 1 month after your initial stroke. And beyond that, I don't really see reason for that, and I would not do antiplatelet agent beyond dual antiplatelet agents beyond 1 month after ischemic stroke. You know, if you have history of atrial fibrillation, that's totally different. You have to use anticoagulation, no antiplatelet. But if you have idiopathic stroke that you think is arterial stroke, that from plaque rupture somewhere, in that case, you know, you do probably just single antiplatelet agent, and you do Plavix if you're on aspirin, or you do just aspirin if you're de novo.
Thank you.
Any other questions, guys?
Though I just got one more. Just is a new patient since they mentioned stroke. So she had a recent stroke, they held her Eliquis because of the stroke, and they said neurosurgery cleared her if she doesn't convert to hemorrhage after the CT, but they recommend Lovenox, not back to the Eliquis. So do we start on Lovenox, not the Eliquis she had before? Or does it matter? Or
So let me tell you something though, if it depends on how massive the stroke is. If the stroke is massive, usually they like to get another CT scan in 2 weeks to make sure there's no hemorrhagic transformation.
yes, sir.
And sometimes they hold it, they hold anticoagulation until we make sure there's no hemorrhagic transformation. Now, for a small ischemic stroke, there's really not much you have to worry about. You can resume anticoagulation as soon as you want, as soon as you can as well. So I would be very careful in this patient population, because the last thing you can imagine happening is for you to start anticoagulation in these patients, and then you have hemorrhagic transformation. So where was that patient? Is he coming or she coming from Orange Park? Let me guess.
North Florida, doctor.
North Florida. Yeah.
I
Yeah.
I discussed it with neuro, and I think she said Lovenox.
Okay, good. Good. Let them handle it. I think that's the best
Yeah.
way to do it.
I was just wondering to myself, like, does it matter which one do you?
I've never used Lovenox after ischemic stroke without making sure that there's no hemorrhagic transformation after a CT scan 2 to 4 weeks after the first event. That's very, very, very risky.
Yeah.
It happened to us actually. One patient we sent back and he had small bleed. So the neurologist said, wait a little bit more before you start anticoagulation. Imagine we starting anticoagulation and this bleed becomes larger. Actually, that happened a couple months ago at our clinic. So I would be very careful with using anticoagulation. And again, that depends on how massive the stroke is. If you stroke MCA, left or right MCA, massive stroke by a wide area, high risk of hemorrhagic transformation, that in that case, you have to be very careful.
Yes, sir. Thank you.
I actually had a patient that had a hemorrhagic stroke back in like 2023 that has AFib. Is there like a certain time frame? She hasn't followed up with neurology since then.
What did that happen?
2023.
That's a long time ago.
Yeah.
That.
So these patients that have like a history long ago. of
No, that
stroke
doesn't apply. No, you're fine. You can wherever you use your old stuff beyond 6 months, that's totally different ball game.
So if we get a new consult, patient had a subdural or a.
I'm not
hemorrhagic
about
stroke,
justice to
we would
resume.
reserve-
Oh, no. 100%, yes. Yes.
Okay,
that's-
Doc, how about oh, were you done?
Yes.
Okay. How about a provoked PE following hip surgery, ORIF in October of 24, November of 24, went back to the ER with C. diff, incidentally found bilateral PEs, put her on Eliquis treatment dose. I take over the patient in June, and she's still on Eliquis 5 BID. No other risk factors, no AFib, no history of clots whatsoever. It's provoked. Now we're in September. I actually have a repeat CTA and bilateral venous Doppler with hopes to DC the Eliquis. I did skim through some different guidelines. Two of them actually say you can continue even
Right.
half dose, but the
Right.
ASC, the hematology guidelines actually said you could discontinue. I was curious what you would recommend there, or which guideline you'd follow.
All right, this is my own guidelines. I would do 2.5 twice a day of Eliquis, half dose of Eliquis, which is reasonable. Your bleeding risk will be much less. Your recurrence risk will be much less as well. Reevaluate in a year or so, and then probably stop it afterwards.
Thank you.
So I am very strong advocate for doing 3 to 6 months of anticoagulation, cut it down to either 10 milligram of the Xarelto or 2.5 twice a day of Eliquis for a year, 6 months to a year, see how your patient does, and then go from there. And again, it's shared decision. You know, probably you read in that document, one of these documents, shared decision with your patients, because you know your bleeding risk will increase, your clotting risk will decrease. So it's a matter of you gotta either you be the advocate for your patient or you tell them, hey, you want clot or you want bleeding.
Perfect. Thank you.
Any other questions? All right. All right, everyone. Good to talk to you guys, and we'll probably meet in a couple of weeks.
Thanks, Doc.
Thank you.
Everyone, chat later.